I'm Dr. Deanna Minich, and I'm the host of the Personalized Lifestyle Pearls. And I'm here with our guest, Dr. Erik Lundquist, who has a clinical practice out of Temecula, California. Welcome, Erik.
Welcome. Thank you. I'm glad to be here, Deanna, and I'm looking forward to our conversation.
Me too. And so we had a call. We did a little bit of a preview on the 24th of May, and we got into some discussion about what we're going to be talking about. The actual title of this Personalized Lifestyle Pearl is about thyroid health, treating the patient and not the labs. Right. So I'm curious because as I had mentioned before, one of the things that I know you for is all of your work with adrenal health. It's almost like, when you and I are speaking in places, usually you're speaking about adrenals in some capacity. So now you're connecting, it sounds like, adrenals into thyroid. And so let's maybe zoom out a bit and just give us somewhat of a connection. Why this adrenal thyroid connection? How strong is it? Do we look at adrenals first and then thyroid? And then we'll whittle down into kind of the basics on thyroid health.
Oh, great. I'm glad you give me an opportunity to kind of tie those in, because you really can't talk about one without talking about the other. But, I do want to preface this just a little bit. There's some decent research, and there's a lot of studies out there that help us understand the physiology of the adrenal, the HPAT axis is what we call that, right? The hypothalamus, pituitary, adrenal, thyroid axis, and how they play in together, and what the physiology and stimulus and triggers and all of that is. But I just want to preface everything that we're going to talk about tonight with we still don't know. We don't know. These are all opinions. These are things that we're seeing clinically. But the bottom line is that the way I may treat and approach somebody from a thyroid perspective may be different than how somebody else is approaching it. And we're not really in this boat of this is the right way, the way you have to do it, and this is the way that you don't have to. You need to avoid this. So I think I just want to be clear that there is no one right way. I'm going to share some of my own experience, my own thoughts, my own understanding of the literature tonight. But I just want to make sure that people maybe listening tonight may disagree with something that you or I say, and that's okay. I want to give permission to people to disagree with what we're saying, because bottom line is we still don't know. Yeah. All right, so that's my preface.
Good to know. And by the way, we've got a number of people signing on. I just want to let everybody know that I'm here looking at questions and comments, and so I can field these to Dr. Lundquist as we go. So back to what he just said, if there is an issue of controversy, debate, discussion that you want to bring up, please do so on the thread, and I will make mention of it. So thank you. So Erik, please continue on then with, your vast clinical experience forms such a great context for this discussion too.
So I think when we look at, going back to your original question, the adrenals versus the thyroid, what comes first? How do we approach it? I think we can't exclude one. They're not individual boxes that we're going to say, okay, let's open the lid to the adrenal box and see what's inside and what's wrong. We'll put back in order and then close that lid and open the thyroid box and see what's in there. And then we look at the sex hormone box and see they're all tied together because they have the same control center, which is the hypothalamus. Right. So the brain is constantly getting these signals. And even the brain is interacting with the hypothalamus in a very special, critical way that adjusts the release of these hormones from the hypothalamus that are stimulating hormones. They then go to the pituitary, and then the pituitary then releases more stimulating hormones that then go to the target glands, which are your thyroid, your adrenals, and your gonads, or your testes and your ovaries. And so you can't say that one doesn't influence the other, because the hypothalamus is the one that's kind of controlling that. So influences coming in are going to fluctuate and change the way the hypothalamus responds. And unlike the adrenal, which really has separate organized areas where it's releasing different hormones, the hypothalamus doesn't necessarily have that. It has glands and cells that interact with the nervous system, and then it releases those hormones and those neurotransmitters in a way that influences the body. And this is, I love the term dance, because it really is kind of a dance. And so the hypothalamus releases the music, and then the pituitary picks up and it starts adding a little more to the music, and then the whole body's kind of responding to this rhythm and this musicality to these rhythms. And then the body releases more hormones that then target ultimate physiology, and which can lead to behavioral change and energy change and aspects, immune dysfunction, things like that. So that's how I see them kind of tying in together. And you really, as far as which one to treat, I think because stress has such a big impact on our adrenals and our thyroid, I think that approaching it from that perspective. So we kind of think of, quote unquote, treating the adrenals first, making sure that the stress component, that balance is there first, and then get into the thyroid. I think of the thyroid as kind of really balancing the gas portion of it. This is the fuel, the fire, the metabolism. So we don't want to put too much gas in the engine if the engine's oil is out, or if there's other aspects of the car engine that aren't functioning. We just start pushing down on the gas. That's going to put a strain on the engine and on the car that it may not be able to handle as well. So that's the way I think about it. Start with the adrenals, kind of try and balance some of that out, and then come in with the thyroid support after.
You've got such great metaphors. I can see you telling patients this, right? The gas pedal, the music, the symphony. We talked about that even last time. Those are great metaphors to understand very complex systems. One of the things that you said is something that another guest that we had on the Personalized Lifestyle Pearls was talking about. Her name is Deborah Maragopoulos. And she and you are very much aligned on this idea of the mother is really the hypothalamus. Who's starting the dance? Who starts the music? It's the hypothalamus. So I'm curious, based on that, why do practitioners treat downstream rather than going to the hypothalamus if that's where all the signals are coming from? I just have that as a question, because she and I were talking about it. It's kind of interesting, because shouldn't we be focused on where that signal is coming from rather than to try to equip the organs? Or maybe it's a bifunctional. We need to be looking at both. I'd be curious to get your thought on that. And maybe we're not sure how to approach the hypothalamus.
Well, I think, like I said in the beginning, I think we're still figuring this out. I think there's a lot that we don't know. I think we're getting better at guessing right, but that we still don't know exactly. And so the problem is that when we were in medical school, what we're taught is that this is how everything goes right, and this is how everything goes wrong. And we're basically taught what to do when it goes wrong. And it really backs up to really penicillin. When penicillin came on the market, that became the silver bullet. And because it cured bacterial infections so quickly, everything in medicine started to shift its approach towards the silver bullet.
Yeah.
And therefore we're treating symptoms. We're treating downstream. If I can just, if I just give this, it'll clear up the symptoms, and now I'm feeling better. So therefore things must be better. But we're not actually looking at the cause and what led to the changes that led to the symptoms. Yeah. And that really wasn't, it was taught a little bit, but that wasn't the emphasis. It wasn't the focus. Everything was on the treatment. What drug do you use? What needs to be cut out, or how do you treat? And if you didn't have a good answer, then maybe it was just in their head. It was a psychosomatic issue. Well, we're realizing a lot of it's in the head, and it has to do with the hypothalamus and the pituitary gland and the amygdala and other things. So there's certainly a adaptive mechanism that happens in the brain that's responding to the rest of the body, that controls what's going on in the rest of the body.
So let's get into the symptoms. When you say treat the patient, not the lab, somebody comes to you, give us some of the portrayals of a person with thyroid issues. Maybe we talk about 3 different ways to categorize this. Maybe the first one is looking at hypothyroidism, then looking at hyperthyroidism, and then looking at autoimmune specific conditions like Hashimoto's. So maybe take us along that spectrum and give us some of the symptomatology, things that you look for specifically, maybe that are well known, but maybe through your clinical experience, you've come into a different way of looking at these different patient presentations as well. I'd be curious to hear about that.
Okay, so I think one of the primary symptoms that people associate with thyroid that also can't be completely separated from the adrenals is fatigue.
Yes.
But one of the ways, yeah, right. So, but one of the ways that I distinguish the two of them is the type of fatigue. So if somebody has fatigue in the morning, and then, they're just struggling to get out of bed and they're getting going, and then by lunch or after they've had breakfast, they start feeling a little bit better, and then they get going and they have a pretty good day the rest of the day. That's not a thyroid issue. That's more of an adrenal issue. Or if they feel pretty good in the morning, but then in the afternoon they're crashing and they're struggling, and then they wake up again right before there's time to go to bed. That's an adrenal issue. But if they wake up and they're tired until the time, and they can't wait to get back in bed, that's more of thyroid fatigue. That means there's just not enough gas in the system. And so they just can't ever seem to get enough energy, enough momentum going through the whole day. And they just feel kind of tired all the time. So that's probably the primary symptom that we see with our thyroid patients. Then there's the other ones. There's other things that I'll ask: constipation, weight gain, depression, hair loss. Maybe they're experiencing a little bit of swelling or bloating. Those are some of the primary ones that we'll see: cold intolerance with hypothyroidism.
Right.
The flip side of that. Oh, go ahead.
Yeah, and so all of those that you just described, we're talking about hypothyroidism. Right. Okay. And at that point, are you starting to look at labs? Do you look at body temperature? Do you ever bring in labs and you say, okay, now is the time, you have enough symptoms, we just want to validate or verify this? Or do you say, let's just work on the thyroid and go from there? Do you use labs to any great extent?
Oh, absolutely. No, I definitely use labs, and because I feel like they help guide the treatment. They're not going to be what I'm going to treat, but I'm going to treat the person. But they're going to guide me, because I may discover some things. And sometimes, even as good a clinicians, and I've, some of my mentors have taught me, when you get to the point where you really understand the functionality of something and you get really good at a physical exam and listening to their history, you don't need labs to dictate your treatment. But I still find I get surprised occasionally. And so I like labs to help me guide the patient with their treatment. But also, I think it's really validating for the patient to be able to see that, yes, there is something wrong, and then have you explain it to them. So many times they've gone elsewhere. Oh, my thyroid labs were normal, and all they had was a TSH. They didn't really have thyroid labs. They just had a screening lab that may or may not have been normal, depending upon what criteria is used to determine whether the TSH is actually in the range or out of the range.
So walk us through, so since these 3 buckets, they're all going to involve these labs, let's just maybe from the get-go talk about, for hypothyroidism, what are the main things that you might be seeing on different labs? Whether you could even mention the adrenals and other systems as well, not just T4, T3, TSH, reverse T3, but really going beyond if there are other things to be looking at.
Right. So I think when you're evaluating the patient, I'm going to stick first just to the thyroid panel, and we'll talk about what I order. But I mean, you have to be thinking about what other things are contributing to the system, because the system's malfunctioning overall, and you need to look at what those influences are. But in looking at a thyroid panel, TSH, total T4, free T4, total T3, free T3, reverse T3 are the primary function labs that I'm looking at. Thyroglobulin, I'll get sometimes if I'm concerned about there being cancer involved. And then also I look at the minerals, selenium, zinc, iodine, sometimes RBC, magnesium, to look at what's going on with the thyroid function. So that's kind of what I consider my thyroid panel. If I'm concerned,
do you include vitamin D in that?
I don't typically as part of my thyroid panel. When I'm starting to get into other aspects, the immune system and what could be influencing gut function, then I'm definitely looking at vitamin D as well.
Okay.
And some of the inflammatory markers. But I think, that's typically my typical thyroid panel. Now, if this is the first time I'm seeing somebody and they're having these symptoms, I will throw in TPO antibodies and TG or thyroglobulin antibodies, because we know that almost 50% of or more of hypothyroid patients are going to have an autoimmune disorder or causality to their hypothyroidism. So I usually do that at the beginning to kind of screen that to see if there's some autoimmune. And those are only 2 autoimmune antibodies. There may be others that we're not really testing for that still could be affecting. There may be up in the 70s and 80th percentile of the amount of autoimmunity that's interfering with thyroid function.
Excellent. That's a very comprehensive panel. Okay, what about hyperthyroidism? Can you talk a little bit about symptoms for that and then get into the labs a bit?
Sure. Now, hyperthyroidism is much less common and is typically associated with Graves' disease or some kind of infection. Usually there's some kind of thyroiditis, some kind of impact on the thyroid gland that's causing it to dump thyroid hormone into the bloodstream. And that essentially then leads to the hyperthyroid symptoms. But it's also really important to understand what those symptoms are, because when you are treating somebody, you want to pick up on some of these symptoms early on so that you don't end up over treating them from a thyroid standpoint. So you're looking at some of the opposites, right? So heat intolerance, loose bowel movements, anxiety or tremors. You can get sweaty palms, you have issues with insomnia, hormone. Women are having menstrual issues that may be changing. So these are all things that come up for hyperthyroidism. But the most common that I see early on is heart palpitations or kind of tachycardia. Yeah. Long before you get into the really severe symptoms. It was interesting. I'm just going to tell you a quick story, but I got asked to sit on as a expert witness for a physician who was placed before the medical board because she had given a patient natural desiccated thyroid and a prescription for a compounded T3, and the patient had ended up having significant overtreatment and ended up with hyperthyroid symptoms. Now, she had written a prescription for T3 to be 0.1 milligrams, so or 0.01 milligrams. So it should have been about 10 micrograms, and the pharmacist filled it wrong and put 1 milligram. So she was getting 1,000 micrograms. This went on for 6 weeks before she ended up in the emergency room. And the physician, because her symptoms came out looking more like a flu situation, low, kind of low-grade fever, and she was having these symptoms, she thought she was having the flu. The interesting thing was this patient went on for 6 weeks at a severely hyperthyroid situation, and yet didn't die, didn't have her heart go into heart failure. I mean, there were so many things that could have gone wrong that weren't. So what that tells me is that sometimes we get so concerned about just going up 25 micrograms on levothyroxine, let alone liothyronine, which is T3, we have a little more room to work with. I think that's something that was kind of hit over my head in medical school, is you have to be really careful with thyroid medication. And not that you don't, you still need to be, but there's a lot more room to work with your patients and help them get to the right state so that they're actually feeling much better, and you're actually managing the functionality of the thyroid hormone homeostasis versus just trying to get your TSH down into a specific location.
Yeah, that makes sense. Again, it's an N of 1, but it's a good example of, that somebody could be on such a level and not have really dramatic effects. So that's an excellent point. So what are some markers that you're typically looking at in labs for Graves' disease or hyperthyroidism?
So with Graves' disease, then you're looking at thyroid stimulating immunoglobulin, or TSI. And the other one is looking at the receptor for thyroid stimulating hormone, or the thyrotropin receptor binding immunoglobulin, or TRBI, or TBII is another way that it's looked at in labs. So those are stimulating the thyroid gland and causing it to overproduce levothyroxine. So those are the antibodies that you would be looking for with Graves' disease.
Great. Yeah, thank you for that. And so, as you mentioned, it's not as common. It looks like we have a posting here. We do have a blog if people are interested in looking at a personal story of Graves' disease. There is a blog link listed here in the post thread. So feel free to check that out. And then let's get into autoimmune thyroiditis and autoimmune conditions, because I believe, in what I have seen, at least clinically, is that they're rampant. I mean, this is, it just seems like perhaps just people are testing more, or what do you think? I mean, do you think that autoimmune disease is on the rise, or are we just testing more thoroughly and being more attentive with symptoms?
No, I definitely think it's more on the rise. And I think a lot of our environmental toxins are playing a big role in this.
Yeah.
I think we're also much more aware of it, at least in the integrative functional medicine world. We're looking for antibodies all the time and looking for immune dysregulation. Mark Houston's a big proponent of the big three, right? He talks about oxidative stress, immune dysregulation, and now I'm forgetting what the third one is.
Was it inflammation or
inflammation? Right. Inflammation. Yeah. Right. So those are the big three. And the key is that's like across the board. With thyroid, we see the same thing: inflammation, oxidative stress, and immune dysregulation leads to dysfunction in the thyroid system just as much as it does in the cardiovascular system. Yeah. So I think that's why we're seeing more and more antibodies attacking in our world.
It's so true. Erik, we're getting a couple of questions here. We've got 2 questions, really good ones too. We're getting a question on, do you ever focus on optimizing T3 and T4 based on the patient's symptoms and lab changes instead of TSH?
That's a great question. So TSH is not the best marker to test thyroid function and functionality. Why? Because thyroid stimulating hormone has one purpose essentially, and that is to go to the thyroid gland, stimulate the thyroid gland to release thyroid hormone, which is mostly a storage hormone, which is T4, which has 4-iodine attached to a tyrosine base. That is a form that won't be active until a iodine is cleaved off of it with a deiodinase enzyme that happens intracellularly or on the cell membrane, which then allows T3 to get intracellular and get into the nucleus and actually activate gene upregulation, turn things on, and get the ball rolling. So if you use TSH as your only marker, then you're not going to effectively treat the patient's true symptoms, and you're not going to get thyroid function. A lot of times with inflammation, oxidative stress, and immune dysregulation, you're going to have some thyroid resistance. What does that mean? Well, essentially, you need more thyroid hormone to get things rolling. So if we just look at TSH and you give somebody supplementation, particularly if you're just giving levothyroxine, which is T4, the storage form, and they're not getting good conversion to T3, you're going to suppress their TSH, so TSH goes down. But essentially, you're going to get more reverse T3, which is the brakes. So now you're going to put more foot on the brakes, produce less gas. The patient's going to feel worse, and yet you're going to say, "Oh, you're fine because your TSH is in the normal level."
Can you talk a little bit about reverse T3 for people who don't know what that is?
Sure. So essentially, when you look at the iodine, or when you look at T4, you've got these 4 iodine molecules. When you cleave one of them and you get 3 iodine molecules, now you've got T3. Well, if you take another thyroid and then you cleave that one, now you've got reverse T3. They both have similar shapes, but when reverse T3 sticks in to the receptor and doesn't allow T3 to bind, now you're not activating anything. There's nothing happening. It stops. It turns on the brakes. It's the way the body uses to help control hyperthyroidism. So in individuals with Graves' disease, when they get an overproduction of T4, the body immediately starts upregulating the deiodinase enzymes that are going to make more reverse T3 than free T3. Because you can imagine the disaster that would happen if all of their T4 started converting to T3 and they start increasing the gas.
Yeah. Okay. Excellent. We've got a number of other questions here. So let me go back to one of the second one that came. This is a good one. It's about nutrition. How do we use nutrients in autoimmune thyroid conditions? And of course, we know that there's some controversy around the iodine selenium biofeedback, or just do you have them together? And so can you talk more about nutrients and autoimmune thyroid conditions? How do you dose? How do you dose? We don't talk about branded names within these Facebook Lives, but maybe just talk about general nutrients.
Yeah, sure. So as you already know, I'm kind of on the other side of the fence with iodine, and that I'm a proponent. I think it's still a really hot topic. But when I dove into the research and I looked to see why there is so much resistance against iodine, it started to become clear, and it really has to do with selenium. So let me explain a little bit. So when they did iodine studies with Hashimoto's, because that's the theory, right? If you give iodine, it's going to trigger Hashimoto's in patients who are hypothyroid. When they looked at those studies, these were all population studies. They looked to see how much iodine deficiency there was, and then they replaced the iodine. They didn't check for anything else. They didn't check to see if there's selenium deficiency, zinc deficiency, magnesium deficiency. They just looked at iodine. Well, that's again just like looking at one shoebox, opening it up and saying all the problems in that one shoebox, and if we fill the shoebox with the right ingredient, we'll be okay. So when they gave iodine without selenium, that actually overstimulated the thyroid gland in such a way that it didn't have the ability to deal with the oxidative stress, because it needs selenium, which is a key component to thyroid peroxidase and to glutathione peroxidase.
Yeah, definitely.
Those are 2 key antioxidants to help balance out the iodine oxidation in the thyroid gland so that it can be bound to the tyrosine base. So when they saw this upregulation of autoimmunity, it was because of the lack of selenium. But nobody talks about that. Everybody talks just about the fact, oh, don't give iodine. So when I looked at that, and I found a couple of studies where they looked at selenium being repleted, and then they gave iodine, they didn't see the Hashimoto's. And then now I've done it. I mean, I've treated hundreds of patients in my clinic where I have given iodine to patients who are Hashimoto's after I've made sure that their selenium levels are where they should be. In fact, even a little bit above. And what I found is that their Hashimoto's improves. It doesn't go the other way. And there's so many patients with Hashimoto's who have low iodine. When I studied just my own patients, and I looked at how many of my patients who had hypothyroidism, whether they had Hashimoto's or not, and had low iodine, I found that over 50% of all hypothyroid patients had low, deficient serum iodine. When I looked at optimal levels, and I like to see in Quest labs above 80 and in LabCorp labs above 70 on iodine, serum iodine, I found that 80% of all of my patients were suboptimal with their iodine. So we started treating them with selenium and with iodine. Now, selenium, I like to look at an RBC selenium and have it above 250. Now, the range only goes up to 300, but I've looked into the research about selenium toxicity, which is another concern. Oh my gosh, we don't want to have selenium toxicity.
I know.
I've never seen it.
Okay.
I've never seen the symptoms associated with selenium toxicity. And when I looked into the research again, the levels where they found selenium toxicity were really up around 2,000, not 500 or 250 or even 350. It was 2,000. So you have a pretty big wiggle room. So I try and keep my patients between 250 and 500.
Now that's in the lab value.
Right.
So when you're dosing, because the tolerable upper level for selenium is, I believe, 400 micrograms. So do you give around that level? You know, just do you do it on body weight? Do you do it based on lab? How do you actually?
No, I do it based upon lab. So I'll do it based upon lab because we know everybody's absorption is going to be different.
Mm-hmm.
So where some person, literally, I've had patients, they're taking a multivitamin that has 50 micrograms of selenium in it, and their levels shoot way up. And I've had other patients where they're taking 600 micrograms of selenium, and they're barely getting into that above 250.
Yeah, it is so different, isn't it? Okay.
So I target more of, I'm looking at the lab to make sure they're getting good absorption.
Excellent. We just have about 5 more minutes, and I want to be sure we get to these questions. So maybe we do these just quick answers if possible, Erik.
Oh, wow.
Some of them require more context. Here is one about, speaking of thyroid resistance, would you say chronic stress and oral contraceptive use would be some of the most common contributors? And what's the mechanism? More bound T4, less free for conversion, and thus action? It's kind of a multi-part question.
Yeah, that's a tough one to answer even in 5 minutes, let alone less than 5 minutes. I would say
that's a whole day seminar.
Yeah, exactly. I would say in brief, yes, it's gonna affect the thyroid binding globulin, which is trapping 99% of all thyroid hormone. It will influence that and then drop your thyroid support to some extent. And then stress plays a huge role in the hypothalamus reacting to that. And stress will cause an increase in reverse T3 activity and therefore put the brakes on the system, as does dieting. You know, when you go into these low calorie diets trying to lose weight, you actually bump up your reverse T3 levels. So it slows the whole metabolism down. So that's why people will eat 500, 600 calorie diets and they'll start to lose weight, but then they feel sluggish. And then as soon as they start eating again, the body turns on the thyroid again. And now they start feeling, you know, a little more energy and stuff.
So to that comment, do we know anything about the role of intermittent fasting, or perhaps I should say, you know, something like a 12 to 13 hour nightly fast or 12 to 16 hour nightly fast and effects on thyroid hormone? Would that have adverse effects?
I don't know the answer to that because most of the studies that I've looked at were in caloric restriction, and you really didn't see an effect until you got around 500 to 600. I don't know about length of time, whether 10 hours, 12 hours, 16 hours, 24 hours, what kind of impact that's going to have.
Yeah. And they're probably different depending on the individual and the diurnal rhythm. There's a question here from Brad. Could indirect calorimeter play any valuable role on evaluating thyroid medication effectiveness? And so looking at, I don't know if you use indirect calorimetry, but that's basically the question. Are there different techniques, devices, things that we can do, even basal body temperature, in order to look at the effect of thyroid medication efficacy?
I think it's a great question. I think it used to be much more common and much more prognostic in our evaluation of thyroid supplementation. But nowadays, I don't think we can trust those measures as much because of the heavy metals and the other toxins that can influence basal body temperature. So I don't use those as much. I look at temperature every time a patient comes in because I want to try and get them in that optimal range of 97.8 to 98.7. But I'm not gonna go and spend a lot of time trying to focus on getting them with their basal body temperature.
Okay. Yep. Makes sense. What about thyroid diseases and osteoporosis from Irma Jennings? Hi, Irma. Anything with bone health that we need to be paying attention to, especially with parathyroid, calcium, phosphorus, mineral balance?
I think parathyroid hormone has a much greater impact on our bone health than thyroid does. I've seen patients where they've had an oversuppression of their TSH, and most of the studies were looking at low TSH and treatment of Graves patients, and then ending up with osteoporosis. And then that was immediately looked at. Oh, if they have an oversuppressed TSH and treatment, they're going to end up with osteoporosis. I haven't seen a study where they've looked at two groups and said, okay, we're going to keep their TSH in this target and look at their free T3 and their free T4 and make sure they're in functional targets, and then look at osteoporosis. It's not been done. So it's more of a theoretical based upon Graves patients, but I haven't seen it clinically with my patients.
Okay, wonderful. And our final question, and this is such a common concern, especially in thyroid conditions, Carol is wanting to know, can hair loss turn around and start to grow again?
Yes, absolutely. If thyroid is treated correctly, then that's the one thing that's leading to hair loss, then yes, that hair will turn around. I had a patient today come in and tell me how her hair was growing again, and she had lots of new stems because she had gotten her thyroid dialed in appropriately.
Yay. I think I do want to mention one more thing, because somebody has a question here about food. What about soy? Can you just
Great.
Soy?
Yeah, so soy. So let's talk about soy and the brassica vegetables, because that's another one that gets brought up a lot, right? The goitrogen. So in the case of soy itself, we live in a country where over 90% of the soy in our country is genetically modified. You can't trust a single study that's being done with genetically modified soy and its impact on health, and then say that whole food group is bad. I think you have to look at international studies and see what's going on there. When you actually look at soy, there's a lot of benefits from hormone balancing because of its phytoestrogen. And then the genetics based upon how soy is digested. There's a lot of factors into it. My recommendation, make sure you have organic fermented soy products, and you're gonna be fine. I haven't seen anybody's thyroid levels change on that. Same thing with the brassica vegetables. Most of those studies are done in animals where they're looking at large quantities of vegetables. Yeah. And I have seen it a few times. And in those patients who are eating large quantities, they're juicing, right? So they're like juicing these big bunches of kale and broccoli and all these, and I have seen it impact their thyroid function. But otherwise, it is, particularly if you steam brassica vegetables, that takes some of the components that lead to interfering with the thyroid function. Yeah. And you'll do fine. We want people eating food and eating lots of healthy vegetable food.
Yes, you're speaking my language. Erik, it's been a pleasure to talk with you. This has been quite the buzz. We're getting so many great comments. We've got a number of blogs posted. As everybody can probably tell, you're a wealth of information and such clinical wisdom you have. And so thank you for giving us a window into thyroid health, some of the things to be looking at. I think that this has been invaluable. So thank you so much for your time. It's been wonderful.
You are so welcome. It's such an honor to share. So thank you so much, Deanna, for asking me.
All right. Well, thanks, everybody. And tune in next time. I hope to see you in a couple of weeks for our next Personalized Lifestyle Pearl. Take care. Have a good night. Bye-bye.
All right. Bye.